Can COVID is an open science collective dedicated to rapidly mobilizing and sharing knowledge to help inform Canada's COVID-19 response. To learn more about us or how to join our community, you can visit our website at cancovid.ca.
Good afternoon or good morning, wherever you are, everyone. My name is Susan Law. I'm the Managing Director of CanCovid, and I'll be your moderator for today. Welcome to this week's session of our speaker series. And I'm very delighted to introduce Catherine Birken, Leigh Vanderloo, and Xuedi Li today, who are going to talk about the public health measures and child health during the COVID-19 pandemic. Incredibly important topic. Dr. Birken is a senior scientist and a staff pediatrician at SickKids here in Toronto and a professor at the Department of Pediatrics at the University of Toronto. Dr. Vanderloo is a knowledge manager at Participation at CIHR and a postdoc fellow at SickKids as well. And Ms. Li is a research analyst at SickKids Hospital. So I'm just going to mention that please do enter your questions into the chat. We'll come back to those at about 3:20 at the end of the presentation, and we'll go through your questions one by one and try to get to them all today. But I'm going to turn it over now to the team from this project. Dr. Catherine Birken.
Thank you so much for the invitation to present today, and I'm really delighted to share some of our work with you and field some questions. Next slide, please. So what we're hoping to speak about today is to learn about children and family adherence to our public health guidelines and health behaviors during the pandemic, to understand the impact of those public health measures on children's health behaviors during the pandemic, to focus in on the association between screen time and some of the mental health outcomes in children and youth, and then to discuss how this research can inform and translate these findings into practice for all the stakeholders. Next slide, please. So let me share with you a little bit about Target Kids. Target Kids is a large primary care research network for young children in Canada. We have been collecting ongoing longitudinal data, really focused at the well-child visits when parents bring their children in to their physician practices. We have to date almost 12,000 children and their caregivers enrolled since we began in 2008. And to date, we have around 15 large practices, mainly around the Greater Toronto area, but also sites in Montreal and Kingston. And our overall goal is really to improve the health of children and their families by optimizing growth and development and learning through preventative interventions. Next slide, please. Well, in 2020, as the pandemic emerged, we thought it was a very important opportunity to launch a Target Kids COVID-19 study of children and families. And we wanted to ask the broad question, how does COVID-19 pandemic impact the health, well-being, mental health, and learning in children and their families? And we did this through administering parent-reported questionnaires, looking at children's health behaviors, their growth and development, their mental health and well-being, their adherence to public health measures that were implemented, questions around their school attendance and learning outcomes, and parent-reported health and community service use. We've also been administering first nasal swab testing and now serology testing. And we've also linked our data to COVID-19 infection and vaccination data through administrative data sources at ICES. Next slide, please. So this is our Target Kids COVID study. As I said, we launched it in April 2020. We've had over 1,350 children from over 1,000 families. We've been collecting serology tests so far on almost 600 families, and we have many, many questionnaires completed thanks to the participation of the families. In our children, the sort of mean age is around 6 years of age, and the parents, the mean age is around 41 years of age. And this is as of November 2021. Next slide, please. And as we began this journey, we worked really hard to identify other cohorts that we were able to work with. And we joined on 4 other cohorts that I'll share with you for other cohorts that were collecting information on children and families focused on mental health. And these are the main investigators in our COVID mental health team. And next slide. And that brought together 4 cohorts. 2 were our community-based cohorts. So Target Kids is one is Spit for Science, collecting information in children in Ontario through the Science Center. One is psychiatry, sick kids psychiatry research. Those are families and children that were provided consultation through our psychiatry department. And POND, which is a Ontario-based cohort focused on children with neurodevelopmental challenges. And I'd now like to turn it over to Xuedi Li, who's going to share some of our published data to date. Take it away, Xuedi.
Thanks, Catherine. Thank you, Catherine. So I will be talking about 2 studies that we did during COVID-19, looking at the impact of the pandemic on children's health. So the first study I wanted to talk about looked at public health preventive measures and child health behaviors using Target Kids data at the beginning of the pandemic. So for this study, we wanted to know whether children's adherence to public health preventive measures were associated with children's outdoor time, sleep duration, and screen time during COVID-19. And we also wanted to know if child sex and age modified these associations. So here is a simple conceptual model for this study. So the exposure was parent-reported child adherence to public health measures. So this was measured using parent-reported number of days per week of children adhering to the following 4 public health preventive measures. So staying at home, limiting visitors at home, avoiding contact, and keeping distance. So we looked at the average of these 4 measures as well as the individual measures to see which of them was more strongly associated with the outcomes. So the outcomes in the study were the 3 child health behaviors. So one of the outcomes, which was child total screen time in the study, was calculated using the sum of these 5 types of screen time. So watching TV or digital media, using social media, playing video games, video chatting, and e-learning. So for this study, we included healthy children enrolled in the Target Kids COVID-19 study of children and families, and the data was collected between April to July 2020. And it was a longitudinal study using repeated measures of exposure and outcome. So we first performed descriptive analysis and then multiple imputation to account for missingness in the covariates. And for the primary analysis, we used linear mixed effects models. And then we performed likelihood ratio tests to test for interaction. So this table shows the descriptive results. So we included 265 children with a mean age of 5.5 years, and 53% were male. So the average number of days of children adhering to these 4 public health measures was 6 days per week. The mean outdoor time per day was about 3 hours. The mean sleep duration was about 10.5 hours. And the mean total screen time per day was about 2 hours and 40 minutes. So what we found is that for every additional day per week that children adhered to public health preventive measures, outdoor time decreased by about 12.5 minutes per day. And there was evidence to suggest that child age modified the association with total screen time. Therefore, the analysis was stratified at 5 years of age based on the Canadian 24-hour movement guidelines age groups. So as you can see, there was a stronger positive association in children greater or equal to 5 years compared to younger children. So we then looked at these 4 public health measures individually. So staying home, avoiding contact, and keeping distance were associated with shorter outdoor time in children. And there was evidence to show that child age modified the association between limiting visitors and outdoor time. Therefore, we stratified the analysis again by age. And you can see a larger effect size in younger children compared to older children. We then looked at the 4 individual measures with child screen time. So there was evidence that child sex modified this association. Therefore, the analysis was stratified by sex, and there was a stronger positive association in girls compared to boys. And we also found child age modified the association between avoiding contact and screen time, and a stronger positive association was found in children greater or equal to the years of 5. And we did not find any association between the public health measures and sleep duration in children during COVID-19. So this study has several limitations. So first of all, the causality and directionality of results cannot be concluded from this association analysis, and residual confounding may have occurred, and parent-reported data may have introduced self-reporting bias. And lastly, this study was nested within a primary care research network and mainly comprises urban children living in the Greater Toronto area, therefore may have limited generalizability. So what we can conclude from this study is that COVID-19 public health preventive measures practiced by children were associated with shorter outdoor time and longer screen time in children. And the association with outdoor time was stronger in younger children, so children less than 5. And the association with screen time was stronger in girls and in older children. So this is the first study that we conducted at the beginning of the pandemic using data from the Target Kids cohort. So moving on to the second study published in JAMA Network Open, we looked at screen time and mental health symptoms in children and youth during COVID-19 using data from the 4 cohorts, as Catherine mentioned. So Target Kids, Spit for Science, the 2 community-based cohort, and Sick Psychiatry and PON, the 2 clinically referred cohorts. So for the exposure of the study, we looked at different types of screen use. So parent-reported different types of screen use in children and youth. So we looked at watching the times children spend watching TV and digital media, playing video game, as well as video chatting. We also looked at e-learning. So during the data collection time period, e-learning was the primary mode of education for children and youth in Ontario as a result of the provincial public health guidelines. So this is the question we use to measure e-learning. So how much time did your child spend on e-learning or online schoolwork per day? So the outcomes of this study were the parent-reported mental health domains. So we used age-appropriate standardized mental health tools to measure the mental health symptoms in children and youth. So for the Target Kids cohort, which is a younger age group, we used SDQ, so the Strength and Difficulties Questionnaire, to measure these outcomes of depression, anxiety, irritability, and attention and hyperactivity. For the 3 other cohorts, which is a little bit older in age, so we used RCAT's T-score, so the Revised Children's Anxiety and Depression Scale, to measure depression. SCARED, which is the Screen for Child Anxiety-Related Disorders, to measure anxiety. The TIDES, which is the Irritability and Dysregulation of Emotions Questionnaire, to measure irritability. And lastly, the SWAN scale, so the Strength and Weaknesses of Attention Deficit or Hyperactivity Disorder Symptoms and Normal Behavioral Skill, to measure inattention and hyperactivity. So for this study, we included children and youth in the 4 cohorts, and the data was collected between May 2020 and April 2021. And again, it's a longitudinal study using repeated measures of exposure and outcome. And we also did descriptive analysis, and then we did multiple imputation, and then we used linear mixed effects models. So this slide describes the daily screen time in children and youth during COVID-19. So in younger children, which is the Target Kids cohort, the mean age was about 6 years. The average time on watching TV or digital media was a little bit over an hour and a half per day. And the average time spent on e-learning were 37 minutes per day. So in older children and youth, screen time was a categorical variable. So the mean age was about 11 years, and about 38% of participants spent 0 to 30 minutes per day on e-learning. About 40% of the children spent 2 to 3 hours watching TV or digital media per day. And if you look at the yellow, gray, and purple part, so about 18% of the children played more than 4 hours of video game per day. And lastly, the majority of participants spent under 30 minutes per day on video chatting. So using data from the 4 cohorts, what we found is that higher levels of screen time was associated with higher levels of mental health symptoms. So in younger children, which is the target kids cohort, higher levels of TV or digital media time were associated with conduct problems, hyperactivity, and inattention. In older children and youth, which is the 3 other cohorts, higher levels of TV or digital media time were associated with symptoms of depression, anxiety, irritability, inattention, and hyperactivity. And then higher levels of video game time were associated with depression, irritability, inattention, and hyperactivity. And we found that video chatting was not protective of the mental health symptoms. So higher levels of video chatting was associated with symptoms of depression. So here I wanted to show you the results table for e-learning in the 3 cohorts. So basically compared to children who spend 0 to 30 minutes per day on e-learning, so this is our reference group, children with higher levels of e-learning time were associated with higher RCATS T-score, and higher score indicates greater symptoms in depression. And similarly, higher levels of e-learning were associated with higher SCARE score, so greater symptoms of anxiety in children compared to the 0 to 30 minutes group. So again, like the previous study, this study has some limitations. So particularly the directionality of results cannot be concluded. So child mental health challenges could have reversely contributed to higher screen use during the pandemic. So in conclusion, this study confirms high levels of screen use in Canadian children and youth during the pandemic. And children and youth with higher levels of screen use were associated with higher levels of mental health symptoms during COVID-19. And different types of screen use were associated with distinct mental health symptoms in children and youth. And particularly e-learning was associated with symptoms of depression and anxiety. So that is our second study on screen time and mental health. And now I'm going to pass the floor to Dr. Leigh Vanderloo. So Leigh will be talking about the meaning and the implications of these 2 studies.
Thanks, Xuedi. So just in the last couple of minutes, we're just going to spend some time on really thinking about, so what do these findings currently mean within the context of what the current recommendations are with regards to children's movement behaviors. So if we move on to the next slide, a bit of a refresher is really just looking at, so what are the current recommendations for children and youth when we think about our movement behaviors? And so if we're looking at the early years, it's currently recommended that with regards to sedentary behavior and screen use, we're really striving for limiting screen use for children 3 to 4, so 1 hour per day. And so again, if we're thinking about what the current recommendations are for optimal health across various outcomes versus what we're actually finding as a result of COVID-19. And then for kids under 2, it's recommended that they're not being exposed to any screen time. If we move to the higher cohort, so these are kids between 5 and 17 years of age, so school age, as well as adolescents, we're looking at that they should be engaging in no more than 2 hours per day of recreational screen time. So there is that little bit of a caveat in terms of looking at recreational versus non-recreational screen time. But again, and probably not surprising if you think of your own households or what you've observed maybe in your own work, is that screen times obviously started to play an even bigger presence in our day-to-day lives, mostly because of out of necessity. So if we move on to the next slide, some of the implications for these findings is that, we've been able to demonstrate or at least show some sort of association between the impact that COVID-19 has had on the various health and mental health outcomes of children and youth in Ontario specifically. We also want to draw attention to the fact that, it's likely that coordinated and collaborative efforts are required across a number of different institutions and sectors within the province. So it's not just healthcare, but we're also looking at researchers, support for policymakers, educators, other allied healthcare professionals, as well as parents in the family unit as well. And when we are speaking about education, it's not just at school, but also thinking about, in the early years. So what does it look like for ECEs and the childcare environment? And how best can we help support these various groups navigate this space, currently, as well as we start to maybe navigate our ways out of the pandemic. What does that look like in terms of engaging in healthy and responsible screen use? So on the next couple of slides, just very quickly looking at what are some of these recommendations for various sectors. So one of the first ones is looking at policymakers. So ensuring that there are resources available to help promote and build awareness around the current movement guidelines. So ensuring that we're aware of what they are. How can we ensure that the institutions for which we do provide mandates or recommendations are feeling that they have the necessary resources in order to help that trickle down, that top to bottom of approach? Also looking at ways that we can invest in no charge active play spaces, looking at urban or semi-urban infrastructure with regards to supporting active transportation, and also reviewing some of the current bylaws that either permit or promote opportunities for active play. So again, providing those opportunities where kids can become more active and hopefully displace some of that added time that we have been allocated to recreational screen use for these particular groups. And again, we get the added bonus that spending time outdoors and just being active can also have a little bit of a buffering effect in terms of looking at outcomes and symptoms related to mental health in these age groups. Next slide. From an education perspective, we're looking at ways that we can help embrace opportunities to incorporate healthy and inclusive movement messages, practices, and policies throughout the day. So school routines or routines within the childcare environment. And so this can look at things such as, ensuring that we're respecting daily physical activity policies or DPA, ensuring that kids are provided with opportunities to engage in active play outdoors, recess, rethinking, when there are disciplinary issues, that we're perhaps looking for other ways other than just removing recess. Minimizing time that is available for free tech use, and trying to, again, break up those extended periods of sedentary behaviors. And also within the classroom, within the childcare setting, that ourselves as the educators are practicing and modeling healthy behaviors, having conversations on why it's important to move our bodies and be mindful of how much time we might be spending in front of screens. Next slide. For health professionals, so this is not only clinicians, but maybe other allied health professionals, is, ensuring when you are making recommendations with regards to the movement behaviors that you are being mindful of the circumstances of various families. So it's not surprising you're going to be working with a number of different families or clients from various backgrounds. And so ensuring that those are taken into consideration when we're providing more tailored recommendations to these groups. Again, part of it is just helping to build awareness. You don't know what you don't know. And especially right now with COVID, there's been so much information circulating and individuals feeling overwhelmed. And so just supporting and providing information about what the current guidelines are, what are the impacts of excessive screen use, where it's necessary or where it might be beneficial, and how can families look towards engaging in healthy amounts of screen use. And then also there's room for advocating for preventive healthcare tools. So some examples that we provided here are the Rourke baby record, as well as the GRIDE record, to ensure that, questions are being asked, or that we're at least having this record of whether or not we're assessing those levels. We're asking the parents on how often that they actually ask their kids or support their kids in those particular behaviors, again, to help build out that record. And then lastly, is really just looking at the parents and caregivers. So again, with all these slides, we're kind of demonstrating that, it is a coordinated effort, lots of layers, and not just one group or individual's responsibility. But when it comes to parents and caregivers, is really helping, how do we make family time active time? So encouraging that there's knowledge about the current 24-hour movement guidelines, helping to establish an environment or culture within the family that, moving and engaging in healthy screen use is something we value. Being mindful of how much time you're spending on your screens, not only for work purposes, but as well as for recreational purposes. So modeling those healthy movement behaviors, not just from them seeing you get active, but also in terms of engaging in screen use. Designating screen-free zones within the house, so no screens within the bedroom or maybe at meal times is another great option. And to also ensure that, there's awareness around that physical activity can be a great way to help enhance social connectivity and social cohesion within the family unit. So we're not looking to displace important bonding time, but maybe finding ways to include a little bit more movement. And then again, trying to increase or encourage more outdoor time. Again, it's a great way to sneak in some additional movement or steps throughout the day, but we also know that we tend to be less sedentary when we're outdoors as well. And so I'll end there, but that's just a little bit of a wrap up in terms of where we hope some of these findings can be implemented against what the current recommendations are in the province. Thank you.
Thanks very much, Catherine, Leigh, and Xuedi. That's fantastic. And back to the sentiment that it takes a village for sure, but really important findings. And even if they're not nailed down in terms of the statistical kind of precision, I think it's just very important associations that I know you're continuing to have a look at. Yeah, that's fantastic. Good. So we'll get to as many questions as we can here. The first is, what impacts on child health can we expect to see in the long term beyond COVID due to these public health measures? Did you have a glimpse into that?
I can take that. Great question. I think we've been really lucky enough and really appreciative of funding through CHR to continue to look at some of these health behaviors throughout COVID and into the next year. So we're hoping, this is longitudinal data, but it's towards the beginning of the pandemic. So we're really looking forward to looking at the changes in some of these health behaviors over time and that relationship to public health measures as they change. And we also have data on these families and children from before COVID. So that gives us a really good opportunity to understand those long-term effects. Really important.
And did you come across sort of any evidence of developmental concerns over time?
Yeah, great question. In terms of development, as Xuedi mentioned, we have the strengths and difficulties questionnaire that we've asked over time. We do have the ages and stages tools sort of before COVID, so we will be able to look at some of those developmental changes. And then we have access to the health records for the families, so we can look at some developmental milestones as well.
Next question is a really important one around long COVID. And I'll just shorten it a little bit. Just what are we doing and how are we acknowledging long COVID in kids? Are you aware of research? Can you provide any sort of insights in terms of long COVID and the implications for children?
Yeah, one of our lead investigators and co-leads of Target Kids, Dr. Jonathan McGuire, is working with the CITF to look at, and 4 other cohorts across the country, looking at some of the long COVID effects. So we're hoping to contribute to that.
Great, so more to come. Next one around, were you surprised to see no association with sleep time and public health measures adherence in children?
Yeah, I mean, I can start with that. So I think, yeah, in terms of looking across, and this has been true across all demographics, is that at the initial one, a lot of, when it was first declared a pandemic and when we started to see the majority of our kind of social shifts with regards to working, school from home, all the uncertainty, is that we tended to see either a shift in that people were sleeping less or they were sleeping more. But within 6 weeks, we started to see with sleep is that a lot of those levels started to balance out or level out rather, and kind of return to pre-pandemic levels, Where we did see the biggest shifts and what continue to be an area where we want to address, and again, this is across the lifespan, but certainly still with kids, is with regards to this influx in spending less time getting active, particularly at higher intensities, as well as that light incidental activity. And then, of course, more time being sedentary, and a lot more time in front of screens. So it seems to be that those two behaviors, although all three are viewed as integrative behaviors, that the biggest form of displacement that we're seeing are across the two, the sedentary and the screen. And so sleep seems to be something that's been a little bit easier to regulate and to monitor, to help have a little bit more of this habit formation with kids being at home. So at least in terms of some of the research that's come across my desk, what I've seen, that's kind of why we've been seeing more of the shifts with regards to sleep and physical activity, because of activities being taken away or not being able to do them versus the sleep.
Thanks, Leigh. I also wanted to add that for this study, we looked at sleep duration only, and we're hoping we have the data on the time they wake up and the time they go to bed. So we're hoping to look at sleep onset or even sleep quality when we have the data. So I think that will tell us more stories about child sleep during the pandemic.
Great, thanks. I'm just going to skip to a couple more. We have maybe 1 or 2 more minutes here. Next one is, can you comment more on the type, age, and any other characteristics of children who are more likely to have depression if they are e-learners?
Yeah, we can pop the paper into the chat, and then because we've looked at the different age groups, we may not have looked in the degree of detail that you'd like, but that's something we can think about for next iteration.
Oh, that would be great, actually, if you could pop it in the chat. Thank you. Next question. Thank you. And then did the investigators ask the children what they missed most about not being in the classroom? What positive and supportive factors occur in the school setting which are absent in an online environment?
Yeah, really important question. We both in all 4 cohorts, we've actually tried our best to harmonize some questions around engagement, motivation, you know, how they feel about what they've learned, and their reported report card scores. So I think what would be ideal is to have standardized, you know, to be able to look at some standardized testing in terms of learning outcomes. And I'm quite worried that we're not going to have the opportunity to do that in the province of Ontario. Certainly, we've not had the opportunity to do that yet. So hoping that we will have some of that data to connect with our longitudinal data.
And there has been not from our particular cohort, but there has been some other published work, qualitative work, that looked at some of the, I guess, the experiences of children and youth, as well as from the parents' perspective in terms of what appeared to be the greatest loss, what they were experiencing, their interaction, as well as looking things, again, from movement behavior perspective, but what appears to be the biggest barriers and facilitators to returning back into sport, into intramurals in the school environment. And so starting to look at not just from the parents' perspective from risk tolerance, but also from children and youth on what they're excited to get back into, or what they're a little bit hesitant to get back into once they are able to return back to in school, if they're currently doing a hybrid or other extracurricular activities.
These are related studies then, yeah.
I can pop some of them into the, so some of them were co-authors on them, but I can add them to the discussion.
Thank you. So 2 last questions here. One is, did you consider socioeconomic status and the outcomes of interest in your 2 studies?
I can speak a little bit about that. So for all of our models in the 2 papers, we did adjust for certain socioeconomic factors. So for example, we adjusted for child age, sex, ethnicity, self-reported income, calendar date, and parental mental health. So that's what we did in the model, but we're hoping through the funded CHR study, we can see if social determinants of health, including receipt of subsidies, loss of employment due to COVID-19, essential worker status, food insecurity, and whether living in a COVID-19 hotspot neighborhood might modify these associations. So, yeah.
Great, thanks. Is it possible to measure depression scores? And in the, I'm just looking for the question here. Oh, I see. For in-class versus online learning for the same children and between children?
Yes, when we collected information on school and childcare, we also asked in which way that children are participating in school, that not it's online, in person, or mixed. And we've also asked standardized measures of mental health. So we will be able to look at that. And there's some work on right now on that question.
Great, thanks. I'll squeeze one last one in here. Has the possible recovery period projection been looked at for children, as in how long it may take them to bounce back from these long-term COVID outcomes on their mental health? Or even in the transition, I presume.
I guess what we can say generally in the data that we've collected so far, there doesn't seem to be all that much change in some of the mental health symptoms. So we have not, in general, seen much resiliency, I think people are calling it. Children that have been struggling, and there's been a very high number of children struggling compared to what we would expect. They seem to persist in struggling so far throughout the pandemic. So I don't know to what degree that informs the next year ahead, but it's been pretty consistent, the mental health symptoms in children throughout the pandemic in our sample.
Great. Well, I think we'll conclude here. Thank you so much to the three of you. Fantastic work, and wish you all the best in continuation of that. Thanks everyone for attending. Thanks for the home team for all of your support in the background there. And just like to say, please do join us next week too, where we will have two people who are leading the guideline development in Ontario and BC, presenting on managing mild and moderate disease in COVID-19 patients, really targeting for primary care providers in that session. So thanks everyone, and thanks to our speakers again, and we'll see you next week. Thanks. Bye-bye.
Thank you.
Thank you.
Thank you.
We would like to thank our speakers and members of our network for their continued support and participation in Canada's pandemic response. If you are interested in learning more about CanCOVID or joining our Pan-Canadian COVID-19 Research Network, please visit our website at www.cancovid.ca.